David Page was not able to travel to be with us today, but he is on the phone from his office in Quebec City, and I'm going to forward your slide deck for you, David. And because he's not here in the room, I asked him to include his photo on his cover page here so you can see what David looks like and see the face for whom you will be hearing from any time now. Go ahead, David.
Cases over the last hour. The only indication I have is how many hands are clapping. So I think it's a pretty big group, but I'm not quite sure. Thanks for the invitation. I would like to have been there and made the trip, but circumstances prevented me. Perhaps I can just introduce myself a bit more before I go on. I've been involved in blood safety and supply issues for now 30 years, really ever since the HIV problems arrived back in the early 80s in the blood system. And I've been president of the Quebec Hemovigilance Committee, which advises the Minister of Health on blood safety issues. And for the last dozen years, until very recently, I was chair of the World Federation of Hemophilia Blood Safety and Supply Committee. So I've got lots of experience learning this. I'm not a scientist. I actually am a person with severe hemophilia B, and so I've learned this from the patient perspective. So next slide. I am the executive director of the Canadian Hemophilia Society, which is a patient organization representing about 30,000 Canadians with a number of different types of inherited bleeding disorders, and we're affiliated with the World Federation of Hemophilia. Another thing we do is we actually started the Network of Rare Blood Disorder Organizations, which is a coalition of patient groups whose members rely on blood and blood products for their lives. These include a number of conditions, some of which you'll be familiar with: thalassemia, sickle cell disease, both of which use red blood cells on a frequent basis. Another one, a primary immune deficiency, which people there use immunoglobulins, which are plasma-derived products. And so we've been working with that group for a number of years, and many of those people were involved in the consultation done by CBS. Next slide. You saw a bit of the history of the numbers of people affected by HIV and hepatitis C back in the 70s and 80s. The hemophilia population was very hard hit. In fact, the majority of the HIV infections in Canada were in the hemophilia population, around 700 of the 1,200. In fact, for people with severe hemophilia A, which is one of the types of hemophilia, close to 90% of those people were infected with HIV, and 100% with hepatitis C before 1990. And as you can imagine, we became very militant and hoping never to see this happen again. And since the mid-90s, we have had seats on pretty well every provincial and national committee that's concerned by blood safety. So we have we have a lot of information that we gather in these groups, and we're able also to raise concerns. So what's our current position? Well, we certainly support the Health Canada's decision to reduce the deferral period to 5 years. It wasn't easy in our group. It took a lot of work for us to convince our Blood Safety Committee and eventually our board to accept this. We finally did manage to do it, but it wasn't easy. Certainly many in the group would have liked to have seen a longer deferral. We also support research into the development of and validation of alternatives to the MSM question that Jennifer was speaking about. But I have to say I'm not optimistic. We've had there have been a number of research opportunities here in Canada and in the U.S. over the last 3 to 4 years to try to develop research questions and ways to look at this. And there's been very little uptake of these research opportunities. So we're not seeing the work being done that's going to eventually perhaps establish whether there are different ways to do this. And as you can understand, we also recommend rigorous surveillance of the transmissible disease rates to be continued among blood donors. If you like to read the full position paper with footnotes and all, you can go to our website to About the CHS in the Public Affairs section, and you can read the full report. Next slide. So many people say, well, isn't the blood system safe now? Can't we relax these measures? And for sure, the blood system, as Margaret talked about, is immeasurably safer than it was in the 1980s. There are many reasons for this. Better screening of donors. There wasn't screening in the early 80s. There's better testing of individual donations, and you saw a lot of the very advanced testing that can now be done on known pathogens. There's much better surveillance of the donor populations and even the general populations, so as to select from among the healthiest donors. And that's not just here in Canada, but worldwide. There's much better surveillance of recipients, so that if disease is transmitted to recipients, it can be identified and investigated. And finally, especially of interest to those who use the plasma-derived products, there are much better manufacturing processes to eliminate transfusion-transmitted infections. Now, Margaret was talking about the development of these procedures for fresh blood components, such as red blood cells, platelets, and fresh plasma. That hasn't happened yet here in North America. It's starting. But we've been lucky enough among those patients who use plasma-derived products to enjoy this for the last 20 years, and as a result, those products have a very high level of safety over the last 20 years. Next slide. But the system, as Margaret said, the system is not perfectly safe. There can be testing errors, there can be labeling errors. These are much reduced compared to past years because of automation. There can also be window period donations. And the other point to make is the risks that Margaret was describing, such as 1 in 8 million units for HIV and 1 in 6 million units for HCV. Those are the risks per unit, but many patients receive thousands of units over a lifetime. People with thalassemia or sickle cell disease receive many, many units of red blood cells per month. And so you have to multiply the risk by the number of transfusions. I think the big question, and the one I'm sure you're asking, is why a population-based deferral and not a very strict behavior-based deferral. Well, blood donor screening around the world is based on epidemiology, and that's looking at disease patterns that are related to specific populations, whether it's a geographic group, a travel group, and certainly it's very clear that higher risks for transfusion-transmitted infections, or TTIs, have been linked to, for example, IV drug users, visitors to certain countries where infections can be endemic, and certainly MSM. And there's been no method developed to reliably assess risk on an individual basis, with very specific behavior-based questions, such as Jennifer was talking about. You could also ask, why not a shorter deferral period, only 6 months, for example, or 12 months, since the window periods are so short now. But donor screening tests can only detect known pathogens. Now, HIV entered the blood supply 5 to 7 years before a test was developed, and hepatitis B and C were infecting recipients for decades before tests were developed. So we cannot say with certainty that the tests today or any of the processes in place are protecting us against emerging pathogens, which would emerge in the same way as say, HIV or hepatitis B. But we do recognize that, again, as Margaret described, science has moved forward a lot since the 1980s. And so we do consider that 5 years would be a reasonable amount of time to protect the blood supply from a pathogen emerging in the same way as HIV or hepatitis B. I guess to end, what would change our thinking? What would allow patient groups such as ours and some of the other ones we work with to say, well, 5 years, we can relax on the 5 years? Well, the first would be the development of pathogen reduction processes for fresh blood components. Now, they exist in Europe for platelets. We expect them to be here very soon for platelets and possibly plasma. Red blood cells is going to take a bit longer, but they would add a third level of safety after donor screening and testing. And then, message which you might not like, but I think something which is quite realistic. Were there to be a reduction in the transfusion-transmitted infection rates among MSM to levels that are comparable to males without a history of MSM activity, that would certainly change the whole ballgame. And that's really my presentation. I would like to really congratulate Jennifer and all those like her who, because of this change to 5 years, feel they're able to go back and continue to donate blood. I think it's a great act, and certainly on behalf of recipients, I thank her. And I thank you for the invitation.